This lecture is going to cover anemia in chapter 34 of your book. So what is happening in the body? With anemia, there's a reduction in either the number of RBCs, or the amount of hemoglobin or hematocrit, bone marrow, the spongy tissue inside the flat bones, and the ends along bones produces those red blood cells, white blood cells, and platelets. The kidneys produce the red blood cell growth factor, erythropoietin, at the same rate as RBC destruction or loss occurs, in order to maintain the constant normal level of circulating red blood cells. So when tissue oxygen is less than normal, we term that hypoxia. The kidneys release more erythropoietin, which then increases the marrow production of RBCs. When the tissue oxygen level is normal or high, erythropoietin levels fall, slowing red blood cell production. The spleen balances blood cell production with blood cell destruction and assisting immunity by removing the aging, damaged, and dead red blood cells, antigens, and microorganisms. It also stores functional red blood cells and platelets. Therefore, anyone who's had a splenectomy has reduced immune functions and an increased risk for infection and sepsis. So a huge part of health promotion for nursing is to encourage appropriate vaccinations and what signs and symptoms of infection to report. Clinical indicators for it, anemia is a clinical indicator. It's not a specific disease, and it can occur with many health problems. There are many causes of anemia, including dietary problems, genetic disorders, bone marrow disease, or excessive bleeding. GI bleeding is a common reason for anemia in adults. The different types of anemia include iron deficiency anemia, vitamin B12 deficiency, folic acid deficiency, immunohemolytic anemia, aplastic anemia, and then anemia is a chronic disease or due to acute blood loss. In iron deficiency anemia, it is the most common anemia worldwide. Any adult with iron deficiency should be evaluated for abnormal bleeding, especially from the GI tract. Vitamin B12 deficiency can either be failure to absorb vitamin B12, which is pernicious anemia, or from an inappropriate diet that lacks the essential vitamins and nutrients, such as a vegan diet. Folic acid deficiency anemia may have symptoms similar to those of vitamin B12 deficiency. However, paresthesias do not occur because folic acid deficiency alone does not affect nerve function. Immunohemolytic anemia, also referred to as autoimmune hemolytic anemia, is caused by immunity problems that for an unknown reason allows a person to form antibodies that attack and destroy his or her own red blood cell membranes, so lysis. This destruction is then followed by accelerated production of abnormal red blood cells. Aplastic anemia is a deficiency of circulating red blood cells because of impaired cellular regulation of the bone marrow, which then fails to produce these cells. Usually occurs with leukopenia, which is a reduction in white blood cells, and thrombocytopenia, which is a reduction in the number of circulating platelets from reduced platelet production. This condition is known as pancytopenia. So a lot of causes of anemia occur. They can include dietary problems, so you're lacking in those green leafy vegetables, liver, yeast, citrus fruits, dried beans, and nuts. And it's the most common cause of B12 deficiency anemia. There's also genetic disorders, bone marrow disease, excessive bleeding, which is GI bleeding is a common reason for anemia in adults, aging, the aging adult. Older adults can still manufacture the amount of blood cells the body needs, therefore anemia is not normal in the older adult, but older adults are more vulnerable as they have decreased blood volume with lower level plasma proteins. As bone marrow ages, it produces fewer blood cells. RBC counts are lower and H&H levels are slightly reduced. Platelet counts are reduced in adults over the age of 60. So refer to page 816 in your book about old adult health adaptations for hematologic assessment. Chronic disease due to decreased production of erythropoietin also is another reason for a cause of anemia. So getting an assessment history, ethnicity is important to assess as many disorders affecting the blood and clotting are inherited. So if a family member has any history of excessive bleeding, you would want to ask. Ask about the drugs that you'll find listed in your table, table 33.2. It includes any over-the-counter herbals and vitamins that can suppress bone marrow, include hemolysis and thrombocytopenia. So make sure you're asking the questions, the use of anticoagulants as blood thinners. The patient may not know what anticoagulant meant, but they might know they're blood thinners, as they're commonly called. Ask about their diet. Diets high in fat, salt, and sugar are linked to the development of anemia. So request a diet recall of at least the past week. And also alcohol intake can cause nutritional deficiencies and impact the liver, leading to impaired clotting. So for physical findings, anemia can be mild or severe. They usually present with fatigue, weakness, and reduced activity tolerance due to decreased oxygen delivery. Signs and symptoms are pretty similar across the different types, with a few differences, such as glossitis with pernicious anemia and a lack of paresthesia with folic acid deficiency anemia. Some other signs for the skin, they'll have general pallor or ash gray skin tone. It's usually more noticeable in the ears, nail beds, palm creases, and around the mouth. Their skin would be cool to the touch, and the patient does not tolerate cooler temperatures. If the anemia is chronic, nails become brittle and concave. You don't want to rely on skin assessment only for any evidence of pallor or jaundice, so make sure you're inspecting those mucous membranes, those nail beds, gums, conjunctiva, and the palmar creases. Inspect the skin for petechiae and large bruises, which is impaired clotting. Petechiae are pinpoint hemorrhagic lesions on the skin surface. And loss of hair on extremities due to a lack of perfusion. But the sparse and absence of hair can be an expected finding in older adults. Cardiovascular signs and symptoms include tachycardia, which increases after meals and with activity. And in severe anemia, abnormal heart sounds such as murmurs and gallops may be heard. The patient may also have some orthostatic hypotension. Respiratory symptoms include breathless on exertion, decreased oxygen saturation levels, causing some fatigue, numbness in hands and feet, paresthesia, and reduced energy levels are neurologic signs. They may also have difficulty walking. Some GI signs and symptoms to look for are anorexia, which is that decreased or loss of appetite, diarrhea, glossitis, and with glossitis, that's an inflammation of the tongue. It's characterized by redness, swelling. The tongue will have a smooth, shiny appearance or appear beefy red. The patient may experience nausea and weight loss as well. So some common labs and tests. Table 33.3 in your book shows you the normal values that you must know. So know the normal values for red blood cells, count, hemoglobin, hematocrit, white blood cells, iron, ferritin, platelet count, D-dimer. The INR, PT, PTT, and anti-10A factor will help you assess how long it takes the blood to clot. Also know the significance of the abnormalities related to client safety. So for your red blood cell count, the normal range for a female is 4.2 to 5.4, and for males is 4.7 to 6.1. The significance of these findings, if it's increased levels, is possible chronic hypoxia, which may be due to, say, COPD, or severe dehydration, or polycythemia vera. If there are decreased levels, you have possible anemia, cirrhosis, or hemorrhage. Your normal hemoglobin for females is 12 to 16, and for males is 14 to 18. So a hemoglobin of less than 13.5 in men and less than 12 in women does indicate anemia. The significance of these counts are the same as the red blood cell count. White blood cell count is 5,000 to 10,000, and critical values are either less than 2,000 or greater than 40,000. Increased levels show an infection, inflammation, leukemic neoplasia or other myeloproliferative disorder, and steroid use. If there are decreased levels, it could be due to bone marrow failure or infiltration, overwhelming infection, or autoimmune disease. Iron levels for females, normal ranges between 60 and 160. Increased levels show hemochromatosis, iron poisoning, hemolytic anemia, or lead toxicity. Male normal range is 80 to 180. Decreased levels include chronic blood loss, dietary insufficiency, and iron deficiency anemia. Ferritin levels, normal ranges for females, are 10 to 150. Increased levels, and then for males, are 12 to 300. Increased levels of ferritin may indicate hemochromatosis, hemolytic or megablastic anemia, inflammatory disease, chronic illnesses such as leukemia or cirrhosis. Decreased levels of ferritin could be caused from hemodialysis. Since iron stores are reduced by dialysis, less ferritin is required. Could be due to iron deficiency anemia or severe protein deficiency. Your platelet counts should be 150,000 to 400,000, and increased levels could be polycythemia vera or malignancy, and decreased levels are bone marrow suppression, autoimmune disease, and hypersplenism. The D-dimer should be less than 500 fibrinogen equivalent units. We'll talk about the INR and the PT and the APTT and the anti-10A in the next PowerPoint. So our problem or anticipated hypothesis is poor perfusion and tissue hypoxia. So we want to maintain perfusion and oxygen delivery to extremities and vital organs by replacing the mineral and vitamin deficiency. In iron deficiency management involves increasing the oral intake of iron from food sources such as red meat, organ meat, egg yolks, kidney beans, leafy green vegetables, and raisins. Oral iron supplements may be ordered. If the supplement does cause some GI distress, it can be taken with meals, but it's best absorbed on an empty stomach. Make sure you're teaching the patients to expect some dark, tarry stools if they're taking iron. Vitamin C actually helps increase the absorption of iron, and food and daily products decrease absorption. So we do also recommend fiber with adequate hydration due to that increased risk for constipation with those iron supplements. So for folic acid and B12 deficiency anemia, it's best managed by identifying adults at risk and then preventing the deficiency. So high-risk adults include those older, debilitated patients, those with alcoholism, malnourished patients, or those with increased folic acid requirements. So a diet rich in foods containing folic acid and vitamin B12 prevents that deficiency. This anemia is managed with scheduled folic acid replacement therapy. So some foods rich in vitamin B12 are animal proteins, fish, eggs, nuts, dairy products, dried beans, citrus fruit, leafy green vegetables. Pernicious anemia is caused by a deficiency of intrinsic factor, so the need for intestinal absorption. So clients require vitamin B12 injections, which usually are begun weekly and then tapered to monthly for the rest of their life. Aplastic anemia is managed differently depending on the absolute cause. For transient or drug-induced aplastic anemia, short-term management may include blood transfusions along with discontinuing the responsible drug. Drug transfusions are used when the anemia causes debility or when bleeding is life-threatening because of low platelet counts. Immunosuppressive therapy helps patients who have the types of aplastic anemia with a disease course similar to that of autoimmune problems. Immunohemolytic anemia is the management Depends on the disease severity. Steroid therapy to suppress immunity is temporarily effective in patients. Immunotherapy, splenectomy, or more intense immunosuppressive therapy with chemotherapy are used if the steroid therapy fails. Anemia of chronic disease, we want to address the underlying cause, may need erythropoiesis stimulating agents. And then anemia related to blood loss, you would, of course, would want to first correct the cause of the bleeding, and then these patients may require either a transfusion or iron supplements or etc. So complications from anemia can cause heart failure. It's due to that increased demand on the heart to provide oxygen to tissues. You have a low hematocrit, it decreases the amount of oxygen carried to tissues, which makes the heart work harder and beat faster. So symptoms the patients would have are tachycardia, palpitations, chest pain, or dyspnea. Some nursing actions we can do is to administer oxygen, monitor our cardiac rhythm, obtain a daily weight, administer blood transfusion as prescribed, administer cardiac medications as prescribed, and administer any anti-anemia medications as prescribed. Blood transfusions lead to the immediate benefit of improving blood cell counts and the signs and symptoms of anemia. Only used when the client has significant manifestations of anemia due to the risk for transfusion complications. RBCs are the most common component given to RBC deficient patients. So you'll want to refer to the best practice for patient safety and quality care in page 855 in your book for your nursing responsibilities before, during, and after transfusion therapy. And then the best practice for patient safety and quality care box on page 856 is the older adult receiving a transfusion and things to look for. I've included a compatibility chart in your handouts for this lecture. And there's also a compatibility chart for red blood cell transfusions listed on page 823 in table 33.5. So just a brief review of the different types of blood products. Blood products come in bags of all sizes, so a unit is the amount of a particular blood product derived from a single donor unit of whole blood. So packed red blood cells are the only oxygen-carrying blood component. In the body, erythrocytes have a lifespan of 100 to 120 days. Red blood cells represent 40 to 45% of your blood volume, and they're generated from your bone marrow at a rate of 4 to 5 billion per hour. Banked RBCs have a shelf life of about 42 days. If we're given red blood cells, these are usually administered to trauma patients, postoperative patients, patients with anemia, or with low hemoglobin hematocrit for many reasons, but typically they transfuse if the hemoglobin is less than 8. Standard administration time should be between 2 and 4 hours. Platelets are the smallest of our blood cells and literally look like small plates in their non-active form. Platelets control the bleeding. It consists of random pooled donors or a single donor apheresis. It's traditionally transfused only to trauma patients with a platelet count less than 50,000. However, a trauma patient's platelets may be dysfunctional despite an adequate number. So we'll also give it to organ transplant surgeries, cancer patients, thrombocytopenia patients, and those are usually transfused at a rate of 5 to 10 mLs per minute or more rapidly based on the patient condition. Plasma is the liquid portion of your blood. Plasma is yellowish in color and is made up mostly of water, but it also contains proteins, sugars, hormones, and salts. It's usually kept frozen and requires time to thaw before administration. Platelets contain albumin, fibrinogen, globulins, clotting factors, and it's commonly administered to trauma patients, burn, shock, clotting factor deficiencies, and DIC. We usually transfuse those at a rate of 10 milliliters per minute or more rapidly based on the patient's condition. And cryoprecipitate, or cryo, is a portion of plasma. It's the liquid part of our blood. Cryo is rich in clotting factors, which are proteins that can reduce blood loss. It's obtained from plasma and contains concentrated amounts of factors 8, 13, von Willebrand factor, fibronectin, and fibrinogen. It's commonly administered to trauma patients, hemophilia A, von Willebrand disease, or patients who need fibrinogen or those in DIC. The transfusion rate set is to infuse within 30 minutes. When administering blood, you want to verify the type and compatibility of the blood component or components received with the appropriate patient identification, their ABO and RH types compatibility, the health record number, the date of birth, and blood expiration date. The checkoff should be done with another licensed nurse or how their facility requires it. You want to inspect that product for any discoloration, gas bubbles, or cloudiness. And as an action alert, the nurse who's going to be infusing the blood product should be the one of the comparing the patient's identification with the information that's on the blood component bag. Infusions must begin within 30 minutes of dispensing from the blood bank, since they can't leave the environment for very long without starting the process of administering. If they're not able to, nurses should return that blood to the blood bank. Vitals are obtained usually prior about 30 minutes or less before the start of that blood transfusion, 15 minutes after start time, 1 hour, 2 hours, and 3 hours after start time, and then 1 hour post-transfusion. Once again, facility protocols may differ. Begin the infusion at 40 ml per hour for the first 15 minutes as a test dose to make sure the patient's not going to have any type of reaction. And then a multi-step function on an IV infusion pump can help make that process seamless. Blood transfusion reactions can either be febrile, hemolytic, allergic, or bacterial. They can take place within 24 hours of transfusion, or delayed reaction can take up to 30 days. So to prevent complications, we want to remain alert during transfusions to detect those early reactions and initiate appropriate management. Instruct the patient to immediately report any change in physical or emotional status, such as new onset joint, back, chest, or abdominal pain, any chills, nausea, feeling unwell, or just feeling uneasy. And this may help identify a possible transfusion reaction. Interventions for reactions occurring during the transfusion begin with stopping the transfusion and remove the blood tubing. For hemolytic or suspected bacterial reactions, we want to return the component bag, labels, and all tubing to the blood bank or laboratory. You would once again follow your facility's protocol. Which may indicate that you initiate the rapid response team, making sure you have a secure IV, keep the access, and flush with normal saline. But you don't want to flush the contents of the blood transfusion tubing into the line, because this would allow more of a reaction-causing blood to enter the patient. Usually oxygen is applied and diphenhydramine is given by IV push. If shock is present, fluid resuscitation and hemodynamic monitoring are needed, and blood pressure support with vasopressors may also be needed. Other drug therapy is supportive in nature, such as administration of antipyretics for fever or antibiotics for that possible bacterial contamination. Table 34.6 shows you potential transfusion reactions and the associated nursing interventions. There's also a handout I gave you in your handouts that should be showing transfusion reactions, the different types. So for patient education and prevention, clients should ensure their diet contains the missing mineral or vitamin. So adequate amounts of iron-rich foods or supplementation, foods high in folate or B12, monitor oxygen saturations to determine the need for oxygen therapy, and administer medications as prescribed at the proper time for optimal absorption using the appropriate technique. So vitamin C can increase that oral absorption, constipation management, take in between meals, stools can appear dark and tarry. Teach the client and family about energy conservation and the risk of client experience dizziness upon standing, and then teach the client about the time frame for a resolution. They'll need to have their hemoglobin rechecked in 4 to 6 weeks to reevaluate. Thank you.